you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Hey, Mike and Matt here with the Ultrasound Podcast. Matt, we've been getting some requests from our listeners recently because they're getting a little sick of us going through the literature quite so much, and they want to just see us kind of do some ultrasounds. So I was thinking, we recently released that DVT ultrasound lecture. Would you mind just showing us how to do a DVT ultrasound?
So here's just a quick 2-minute video on how to do the DVT scan, the compression ultrasound to rule out DVT that we talked about on a recent podcast. This was me demonstrating how to do it at a recent Kentucky ACEP course that I taught.
Our high frequency probe, we got great resolution with this, a great picture, and this is a superficial object, so we don't need to penetrate very deeply. We position the patient like this with their leg kind of bent out. You can increase the size of their popliteal and stuff if it's going to be a small one, you have a hard time finding it, but maybe putting their leg off the bed, you could do that way or anything, but that's usually not necessary. It's usually fine to get both spots, or 2 points. So the first one, the common femoral vein, take off of the saphenous. So just like you're going to do a femoral line. A femoral line, same spot, you're looking at the artery and vein. We got our probe marker to our left because the marker on the screen is to the left. We place it up here. One thing that sometimes can mess you up is if your depth, if you come up to the machine and you haven't adjusted the depth and somebody's been looking for like a foreign body, something really superficial, and you're looking like this, you cannot see the artery and vein anywhere here. I actually have a confession to make, a false positive, the one false positive that I've had a few years ago. I was scanning, first learning how to kind of do this, and I scanned, and there was a big lymph node on the screen right here, and it looked just like a clot. And I got so excited, I was like, all right, it's a clot, and we're done. And I walk away, not realizing that, well, there's no artery there. This is not right. So that is a false positive that can happen. But if you come up here and you don't see anything, increase your depth till you see, you know where the femoral artery and vein is. If not, feel there. You can palpate it. And right there, we see it. Everybody see the artery on the screen? I'll throw some color flow on there so you can see it lighting up better. The vein, slow flow, that artery pulsating there. Really nice. So now you've seen that. So what about right here? I'm compressing here. Does that vein completely disappear? It does. Is that good enough? No. I need the saphenous take off. So it's always higher than I think. I always start too low. So I'm scanning up, 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 up. So there. Do you see that? You see it right here. Right here, dude. See it on the very top? I'm way high there. It's really not comfortable touching my dad on his thigh this high. But you have to get comfortable with your patient. This is no modesty here. So now I'm at this point. And I compress, completely disappears, right? See that? It's gone. There's just an artery left. So that's 1 point down. Second place behind the popliteal. There it is. Everybody see that? Popliteal artery on the bottom, vein on the top. No clot. So how long does this take? Somebody time me. We're going common femoral, vein, there's a saphenous. That compresses. Back here, artery, vein, that compresses. That's pretty quick. That doesn't take a lot of time.
You know, Mike and I sometimes disagree on how to teach DVT ultrasound. I say, hey, let's keep it simple. Let's teach 2-point compression. It's been proven in the literature to safely rule out DVT. And then Mike says, yeah, but augmentation's really cool, pulse wave, blah, blah, blah. And you know, everybody's entitled to their opinion. I think it's totally within his rights if he wants to be wrong on this. So if you're not happy with a quick, evidence-based approach to ruling out DVT like I just taught you, then here's Mike to muddy the waters. Unbelievable.
Thanks, Matt, for that excellent description on 2-point compression technique DVT ultrasound scanning. I think you did a pretty good job of really convincing people that this is something that's pretty easy to do, pretty teachable, and fairly quick to learn. Although I really haven't seen anyone get quite that intimate with their father before. It's a little awkward, but we still really appreciate the education. I just wanted to take a quick minute and go over a couple of things, my 2 cents on DVT ultrasound, because I think Matt and I do this just a touch different. Matt tends to take the little bit more simplistic approach to DVT ultrasound by just using that 2-point compression technique, where I tend to add just a couple of more things to my DVT ultrasound, which I don't think necessarily adds a lot of time, but maybe it makes me feel a little bit better about things. So I'm going to go over those. The two things, augmentation and pulse wave Doppler, and we're just going to spend a minute talking about the two. So first off, augmentation. An augmentation maneuver is really a fancy name for squeezing a patient's calf, and that's why you've got color flow on their common femoral. So here we're looking at the femoral artery and femoral vein, and what you see there is we're beyond the point of the artery bifurcating, but we're at the level of the common femoral vein. I know that because it's beyond the point of the saphenous takeoff. And all I'm really doing is putting a color flow box over the vein. And you can see when I'm not squeezing the calf, there's really no flow through that vein. But then I give a quick compression squeeze just to the calf. Doesn't take much. And it shoots a rush of blood up through the vein and gives me that really brilliant flow. And what that's telling me is, not only is it telling me that there's fairly good connection between the venous structures in the calf and the venous structure at the level of the common femoral vein, but it's also telling me that blood is continuing to progress more proximal. So if there was a big iliac or IVC thrombus preventing proximal flow of blood, then when I squeeze, there would be already a column of blood there that can't go anywhere, so you wouldn't get that big increase in color flow velocity. And you can also look at that with pulse wave Doppler. So here, this is an example of an augmentation maneuver where I've put the gate of the pulsed wave Doppler right in the center of the vein, and you can see that the velocity is right in the center of the screen here, increase up to about 50 centimeters per second during that augmentation maneuver. So that's augmentation. It's fairly easy to do. It makes me feel more comfortable that there's not a big nasty thrombus sitting in between my 2 points of compression in the technique that Matt told you, and also makes me feel a little bit better that there's not something more proximal. There's another technique though to evaluating for the possibility of an iliac thrombus, and that's just looking for phasic flow. And all you're doing here is you're basically looking at the pulse wave Doppler in the common femoral vein, and you're looking to see if there's any respiratory change. So there should be, right? So when I take a breath in or when I exhale, I'm creating positive and negative intrathoracic pressures depending on the respiratory cycle, and that causes flow to either increase in my common femoral vein or decrease, and that's because the common femoral vein is so close to that central venous circulation. So here we're looking at pulse wave Doppler right at the level of the common femoral vein, and you can see that there is phasic flow. So there's some evidence that there's a change in respirations. You lose that when you have a big iliac thrombus or when you have a big IVC thrombus, because there isn't any change in pressure because the thrombus is occluding the vein. And this is an example of what it would look like if there was a thrombus there. So if there was a thrombus in the iliac, not necessarily at the level of the common femoral vein, then I would get what they call monophasic flow, and that's where there's no change in the velocity of the flow based on the respiratory cycle. So those are the two things I add into my DVT ultrasound. I don't think it really takes me more than about 30 seconds, maybe 45 seconds to do those few extra things, and it makes me feel a little bit more comfortable that there's not a big nasty iliac thrombus waiting to pop off and stick right in the right main stem. Alright, thanks everybody. That's DVT ultrasounding in 5 minutes or less.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.